para ello tenemos el placer y el gusto de tener a Paul Vavalle. Él es el director del programa de TAVI o TAVR, como se dice en Estados Unidos, de la Universidad de North Carolina. Y él desde 2014 está en esta posición. Tiene una amplísima experiencia en este sentido. Se entrenó en Duke hace años y desde hace muchos años se encuentra ejerciendo. Dará las 2 primeras pláticas y para entrar en materia le pediré, John, please come and sit right here and enlighten us with your knowledge about TAVR, please.
Thank you. See if we have the slides. Well, thank you very much for that kind introduction and for the invitation to be here. It's really my privilege to be here. Thank you to the coordinators for inviting me to this fantastic conference, and thank you to all of you for hosting me in your beautiful city. I am going to give 2 talks here on TAVR and complex anatomy. The first one being a little bit more of a philosophical talk as we talk about pushing the limits of TAVI and where is the field going and what are the things that we're doing as we're pushing the limits for anatomy. And then the second one will focus much more on bicuspid valves in particular. So we continue to push the boundaries of this technology. It continues to mature, and as operators, we continue to expand the boundaries of what we are willing to treat. With increasing experience and confidence, we are taking on increasingly challenging cases. Sometimes we fail, and we must learn from those experiences, but with each success, we are emboldened to push the limits even further. So when I was asked to give this talk and I was asked, what is the limit of TAVI, I immediately began to think about these amazing images that we're just seeing from the James Webb Telescope. What is the limit? What is the limit of the universe? 20 years ago, we could not have even imagined seeing pictures like this and seeing this far deep into the universe. When I think about what is the limit for TAVR, 20 years ago, I'm not sure any of us could have imagined some of the things that we're doing with this technology now. So I don't know what the limit is, but what I do know is that we continue to push the boundaries and we continue to get better as operators with our experience. So what I hope to do, though, over the next 15 minutes is share with you some case examples of where I feel like we did push the limit and share with you some of the lessons that we've learned from these examples as we've continued to expand the number of patients that can be helped by this technology. This first case is a 78-year-old man with severe aortic valve stenosis, class 4 heart failure symptom, low ejection fraction of 35%, prior open heart surgery with bypass, stage 4 kidney disease, very frail. Our heart team assessed him to be at extremely high risk for surgery, essentially inoperable. And so we began to work him up for CT scan, for TAVR. And on the CT scan, we noticed this. An area over 900, an extremely large annulus, well outside the indications for use for transcatheter valves. But what other options do we have? He's not operable. He's class 4 heart failure symptoms. He is dying from his aortic valve stenosis. He desperately wanted us to try something. He has very large sinuses consistent with his large valve altogether. But we had a number of questions. Will there be severe paravalvular leak? Will the valve maybe even embolize because this area is so large? How will the valve seal? And so we began to try to model how a valve might look in there. And this is using the circle method, trying to model what a 29 millimeter valve would look in this position. And you can see it almost looks lost. It's a 29 valve, but it looks so small in these enormous sinuses. So will this work? And so we began to say, okay, well, 29 is probably our best option, a 29S3. We should probably hard prep it, add extra volume. How much? Well, in talking to others who've done this, anywhere from 3 to 4 to 5 to 7 to 8 milliliters. The engineers tell us that the risk of balloon rupture really begins to go up at plus 8 millimeters with the 29 balloon. So we decided 29S3 plus 7 milliliters. And hopefully we could seal at the level of the leaflets. There was no way we could make a seal at the level of the annulus, but maybe we could seal at the level of the leaflets. And you can see with this very overexpanded valve how foreshortened it is. And so when you do this overexpansion, you have to start much deeper than you typically would, because most of the foreshortening happens from the ventricular side up. And the result was impressive. Single-digit gradient, trivial leak. This echo picture is a still picture, but you can see trivial paravalvular leak. We were thrilled, and we were also relieved that this was able to work as we pushed the limit. And he had dramatic improvements in his symptoms. When I saw him at the 30-day follow-up, he said, "I feel like I am alive again. I have no trouble at all. You don't know the difference this has made for me. It's the best medical procedure I ever had. I feel 110%. He and his family were so incredibly thankful. These are the reasons why we continue to push the limits and why we need to continue to expand the boundaries. Our patients really depend upon this. Here's another example. 61-year-old man with class 4 heart failure symptoms, very severe aortic valve insufficiency, low ejection fraction. He too is extremely frail. Body mass index of 15. Because of a history of esophageal cancer, he's had his esophagus removed. He's dependent upon tube feedings, has severe COPD. Our heart team assessed him to be inoperable, at extreme risk for open heart surgery. But now he's in front of us dying with heart failure from severe aortic valve insufficiency. On CT scan, he has no calcification, none. It's a dilated root, it's a dilated aorta with zero calcification. Can we use TAVI for this? We do not have in the United States an FDA-approved valve for aortic valve insufficiency. So we elected to use a 23S3, a 26S3 over a 23S3 because the 26S3 provided adequate oversizing. It gave us almost 30% oversizing. And we went in with nominal prep at first. We felt like 26% oversizing might be sufficient. But would the valve migrate? Would it embolize? How much leak would there be? Thankfully, there was none. This valve gave us an excellent result with no aortic valve insufficiency. It worked. It worked for this problem and helped this gentleman quite a bit. This isn't a case we did, but yet another example of pushing the limits. This was a case done in Asia that was published in JACC Interventions. This is extreme aortic aortic tortuosity. Can you deliver a transcatheter valve through this? Well, they were able to do it. How? Bilateral Lunderquist wires, so very stiff wires from both femoral arteries to try and straighten out the tortuosity. A long hydrophilic gore dry seal to try and navigate through this. And then the use of a snare to snare the valve, to pull it through and to help position it into place. So again, pushing the limits of what we initially began to use this technology for, helping sicker and sicker patients with more and more complex anatomy. What about very horizontal aortas? This happens very commonly. We see many patients with very horizontal aortas. It poses a number of challenges, difficulty in crossing the valve. You lose pushability of the delivery system. Oftentimes the force is being lost on the outer curvature of the aorta. It's sometimes harder to find the coplanar view on fluoro. It's difficult to take the parallax off the valve, which becomes increasingly important in our self-expanding valves. Oftentimes the valve is very canted upon deployment, and it's really much harder to adjust the depth during valve deployment. So a lot of challenges that horizontal aortas present. But we've gotten better. I think using AL1 or even AL2 catheters to cross the gap valves gives you more steerability and allows you to better cross the valve. I believe that in these very horizontal aortas, a more aggressive pre-BAV, we've largely moved away from doing pre-BAV for TAVR, but I think doing it in these situations and maybe being even a little bit more aggressive than you might be with balloon sizing will then help with pushability and delivery of the transcatheter valve. The flex system on the S3 Commander delivery system really helps in navigating this, but sometimes even that isn't quite enough. And then you can use some of the more flexible delivery systems out there like Accurate and Portico, and the next generation Evolute FX delivery system is supposed to be much more flexible and deliverable. But many times you need to use like a snare, oftentimes from a radial approach or contralateral approach to snare the valve as a way to help pull it down into the valve and help align it and make it coaxial to the valve plane. Here's another example of risk of coronary obstruction, not from small sinuses or from large leaflets, but from stents that are hanging out into the aorta. The right coronary stent is sticking out more than 6 millimeters into the sinus, and the left main stent as well, a couple of millimeters. Will the valve interact with the stents? What valve type is best? Balloon expandable? Self-expanding? Does a balloon expandable more likely to crush the stents? Well, what about self-expanding? What happens if you crush these stents? How can we protect coronary flow? The patient based on annulus size for either a 23 Edwards S3 or 26 Medtronic Evolute. We elected for the 23 S3 strictly because it was a smaller valve size and we thought it would be less likely, or there might be less interaction with the stents. But we were still certain that the valve would interact with the stent, particularly the right coronary stent, which was protruding quite a bit into the sinus. So we decided to pre-wire the right coronary artery, have a coronary balloon mounted on the wire, parked in the right coronary artery, ready to re-expand the stent after valve deployment. And so here we are with the valve deployment, and there's a lot going on in this picture. But there's a JR guiding catheter engaged into the stent in the right coronary artery. There's a guide liner, guide extension catheter that is extended well into the right coronary artery. We have the coronary artery wired and a balloon size 1-to-1 to the stent, which was a 3/0 stent, parked in the right coronary artery so that if we crush this stent, we have the balloon in position to reopen it. And you can see as the valve is being expanded and being deployed, we are certainly interacting with the stent. The guide liner, the guiding catheter are all being displaced by the expansion of the stent valve. And so there is no doubt that at this point we had disrupted the stent of the right coronary artery. But we had the balloon in position ready to go and immediately pulled the balloon back, re-expanded the stent, and thankfully the stent fully re-expanded and was able to actually place itself above the stent frame of the transcatheter valve, and we're able to quickly restore flow in that right coronary artery. To be honest, if I was doing this case again today, I might actually use a slightly different technique. I might use a kissing balloon technique. I might actually have this coronary balloon parked in the right coronary, just as it is here, inflate that balloon, and then inflate the transcatheter valve to prevent the crushing of the stent frame to begin with. Thankfully, though, this technique worked. We were able to quickly restore coronary flow, and the patient did well. So in summary, we continue to push the limits of the degree of difficulty we are willing to tackle with TAVI, with increasing operator experience, with improvements in technology, with improved imaging. We continue to push the limits. And what is the limit? I don't know what the limit is. That's for all of us to find out together as a community as we continue to work. But what I do know is that our patients are depending upon us to continue to push the boundaries. So thank you very much for your attention, and I'll transition on to my second talk here in just a minute. In this next talk, I'm going to talk a little bit more specifically about the challenges of bicuspid valves, and yet another area where we are certainly pushing the limit as we continue to learn more and more about the treatment of bicuspid valves and the applicability of TAVR. It's certainly a complicated area because these patients oftentimes are younger, and many of them have other problems such as aortic aneurysms and other anatomy that may require operative surgery. Great. If we could start from the beginning. Wonderful. Okay, thank you. Perfect. Okay. So over the next 15 minutes, what I'd like to do is give you a brief overview of some of the data that we have to support the use of transcatheter valves in bicuspid aortic valve stenosis. And then what I hope to do is spend the majority of the time sharing with you tips and tricks that I think help us in navigating this complex anatomy for transcatheter valves. As you all know, bicuspid valves are very common. Almost 2% of the world's population has a bicuspid valve. It's the most common congenital heart defect. And about a third of these patients will go on to develop complications such as severe aortic valve stenosis that will require intervention. The prevalence of bicuspid valves increases with younger age. As we know, bicuspid valves tend to degenerate at a much faster rate, and so these patients present to us with severe symptomatic aortic stenosis, typically at a younger age. In the United States, TAVI is increasingly being used to treat aortic valve stenosis and bicuspid valves. This is an analysis from the United States TVT registry showing that there has been consistent growth year after year in the use of transcatheter valves to treat bicuspid aortic valve stenosis. In all comers, that percentage increased from 2.8% in 2015 to almost 7% in 2020. But the biggest growth was in our young patients, in patients younger than 65. Not surprisingly, that had the biggest jump in the percentage of patients being treated with TAVI. Now over 20% of patients age 65 or younger being treated with TAVI in the US have a bicuspid valve. Raj Makar and others looked at the outcomes of bicuspid valves undergoing TAVI and compared that to the outcomes of patients with tricuspid valves, also out of the US TVT registry. They looked at over 3,000 propensity-matched low-risk TAVR patients comparing bicuspid to tricuspid valves, and there was no difference in death, stroke, paravalvular leak, procedural complications, or valvular hemodynamics. In fact, numerically, the bicuspid patients had a lower mortality, although not statistically significantly different. And so on face value, you might say, well, TAVR seems to be a good option for bicuspid valves. But I would say be very cautious about applying this data broadly to all bicuspid patients. These were patients who were selected for TAVR, patients who were assessed by heart teams at institutions across the United States, patients whose anatomy was felt suitable for bicuspid valve, for TAVR treatment. And so this is a carefully selected group of bicuspid patients who were vetted by heart teams and felt to be suitable for TAVR. We do not have any randomized controlled trials looking at the role of bicuspid valves, the role of TAVR in bicuspid valves. Although we do have some data from a randomized controlled trial, the Partner 3 trial, the low-risk Edwards TAVR trial, did have a bicuspid registry built into it. And they looked at 148 propensity-matched pairs comparing TAVI in bicuspids versus tricuspid valves, all out of the Partner 3 study. And again, showed similar outcomes with the patients with bicuspid valves. Similar in death, stroke, rehospitalization, heart failure class, paravalvular leak, valve hemodynamics. And so if you read this study superficially, you might again say, okay, bicuspid seemed to be completely appropriate for TAVI. But I would say be careful, because if you read deeper into the study, you will see that this is a study of only 148 patients. In fact, 320 patients were submitted to the trial for treatment in the trial for bicuspid TAVI. And about half of them were excluded because of anatomical reasons. And you can see in this chart the reasons: severe raphe calcification, ascending aorta is dilated, severe LVOT calcium, risk of coronary obstruction, severe raphe calcification with severe LVOT calcification. So the patients, the 148 patients included in this study, were very carefully selected patients, patients chosen to have really good, despite being bicuspid, to have really good anatomy for TAVR, that the study team members felt their anatomy led to a high chance of a very good result with tricuspid, with TAVR. And so these are carefully selected patients that are being studied in this group who had really pristine anatomy despite being bicuspid for TAVI. Most of the patients, again, that were excluded for anatomic reasons. Why? Well, because anatomy matters. Every bicuspid valve is shaped differently. You must assess each valve individually for the raphe, the degree and distribution of calcification. Remember the Sievers classification. We use this as a way to communicate the types of bicuspid valves, type 0 with no raphe, type 1 versus type 2. The overwhelming majority of bicuspid valves you will see will be type 1 with a single raphe. But remember, it's more than just the valve. When you're looking at the CT scan for patients with a bicuspid valve, remember to look at the aorta. Many of these patients have a dilated aorta. Look at the coronary arteries. Many of these patients have anomalous coronary arteries, and it's not uncommon to have very low takeoffs of the coronary arteries, increase the risk of coronary artery obstruction. Many bicuspid valves are more elliptical in shape with eccentric calcification. They have long and asymmetric leaflets and cusps. The orifice, which is the distance between the leaflet tips, is sometimes different than the size of the annulus, and that has important implications about valve size choosing. If you choose a valve based strictly on the annulus, but you have very small orifice, you may in fact oversize the valve and increase the risk of root rupture. An eccentric flow can lead to root aneurysms and very horizontal aortas, further complicating and increasing the complexity of these cases. This is a really important study that has really begun to help us understand the types of anatomy that are at highest risk for complications with TAVR. This is a study by Yoon and multiple colleagues globally evaluating CT images as a way to try and predict which patients are at highest risk for complications with TAVI. And they basically looked at two major things. They looked at the degree of leaflet calcification and the degree of raphe calcification. And you can see A and B on the left are tricuspid valves, the top row with mild calcification, the bottom row with severe calcification. C and D have no raphe. It's a type 0 bicuspid, but again, the D has much more severe leaflet calcification. E and F is a type 1 valve that doesn't have calcified raphe, but has mild calcification leaflets in E, severe calcification leaflets in F. G and H, though, are the most important ones to look at. These are the patients who have calcified raphe with or without heavily calcified leaflets. H is the most dangerous anatomy type. It has both calcified raphe and calcified leaflets. And that's the anatomy that's associated with the highest risk of complications with transcatheter valve replacement. And here's the data to support that. The patients in dark blue with no calcified raphe and no excess leaflet calcification had really good outcomes, pretty much on par with tricuspid valves. But if you had either calcified raphe or heavily calcified leaflets, the outcomes began to get worse. And in this case, almost a doubling in the mortality. But if you had both severely calcified leaflets and severely calcified raphe, the outcomes were far worse, with a mortality at 2 years of almost 26%. Almost 5 times that of the patients without either of those findings. Not only that, they had a higher rate of death, aortic root injury, 5 times the rate of aortic root injury, and moderate or severe paravalvular leak. So anatomy matters, and it's important to spend time looking at the CT and trying to understand leaflet calcification and raphe calcification. So I'll close with a couple of cases. So this is, before I do the cases, a couple more considerations with the anatomy. The degree and distribution of calcification is important. The annulus size and shape is very important, often larger and elliptical. The coronary takeoffs are another important thing to look at, with low and anomalous coronary takeoffs more often present in bicuspid valves. Many times you will find long leaflets, so a fused right and left cusp leaflet. Unpredictable how that leaflet will be displaced with TAVI. Where will that leaflet tear? How will that leaflet behave? Will it stand up as one straight long leaflet, and even with high coronary takeoffs may still obstruct coronary flow because of the extra length of that leaflet? Don't forget about looking at the aortic root. If the root is dilated and the patient is low surgical risk, probably goes to surgery to correct both the valve and the root dilation. Many of these patients have very deep sinuses. While I don't think that prohibits TAVI, it may theoretically increase the risk of valve leaflet thrombosis, as there are these deep wells that are formed in the sinuses adjacent to the transcatheter valve. And as you look at these valves, thinking about where will the transcatheter valve seal. If the orifice or the intercommissural distance is smaller than the annulus, plan to seal at the level of the leaflets. In fact, if you size your valve based on the annulus and your intercommissural distance is smaller, you increase the risk of root injury. So here's that concept explained a little bit. In the majority of patients, 88% in this study, the intercommissural distance, again, which is that distance between the commissures at the level of the leaflets, is either the same size or larger than the annulus. And so in those cases, you're safe. Choose your valve based on the size of the annulus. But if you're in the 12%, where the intercommissural distance is actually smaller than the size of the annulus, you will probably choose the valve more based on the intercommissural distance than the annulus, because if you choose the valve based on the annulus, you run the risk of higher complications of the root. And so here's an example of a 69-year-old man with hypertension, hyperlipidemia, class 3 heart failure, severe aortic valve stenosis by every metric, no significant coronary artery disease. Our heart team assessed him to be very low risk for open surgery. He's a fit, highly functional 69-year-old man. And we as a team decided to send him for open heart surgery. This is not a case that is prohibitive for TAVR. I think you could do it and probably get away with it. But the extreme leaflet calcification gave us pause. And in somebody who is young, active, very low risk for surgery, his chances of doing very well with surgery are very high. Yet the potential complications of root injury, coronary obstruction are disastrous in someone who's otherwise young and healthy. And so as a team, we decided to send him for open heart surgery. Here's a 75-year-old man who's sicker, class 3 heart failure, stage 4 kidney disease, coronary disease with prior PCI, preserved ejection fraction, but severe AS, adequate transfemoral access. He's got a bicuspid valve whose anatomy is a little bit more favorable. He's got a type 1 fused right and left cusps. He has some moderate calcification in his leaflets and some calcification of that raphe. And when we size him, his annulus really sizes sort of on the border between a 26 and a 29. And so we begin to use this circle method, this virtual ring method, where we try and imagine how a valve will fit into this space. And so this is what a 26 valve would look like. Maybe would leave a little bit of room at the level of the annulus, but at the level of the leaflets appears to cover most of the intercommissural distance. When we look at a 29, though, it definitely will give us a seal at the level of the annulus and at the level of the leaflets, but that bottom center picture really gave us concern. A 29 will really displace this heavy calcification on the leaflets and the raphe, and you can see with the 29 valve, there just isn't any room for this displaced calcium. Where is this going to go? And so we were concerned that a 29 valve would increase our risk of root injury, and so based on these pictures, we went with the smaller valve size, the 26. We did standard prep, no extra volume in the delivery system, and we were able to get a great result. Mean gradient single digits, no paravalvular leak, discharged home the next day, and we avoided catastrophe with root injury and got a nice result for this gentleman. And so for those of you unfamiliar with this circle method, this virtual ring method, it's a helpful tool in these borderline cases. Basically, you look at the CT scan and you draw in a circle that's either 26 or 29 or 23 millimeters, depending on the size of your valve, and you place it at the level of the annulus, and at 3 and at 6 and at 9 millimeters above the annulus. And that gives you a sense for how the valve might sit and how the valve might interact with the leaflets, and gives you a sense for what happens with the displacement of the calcium when you expand the valve. And in this case, a similar case where it was borderline between 26 and 29, this virtual ring method, in fact, it wasn't even borderline. By the annulus alone, it should size for a 29, but this virtual ring method raised concerns about what would happen at the level of the sinuses, and so it encouraged the team to downsize, and they did to 26 and got a good result. And I must say that in our experience with the Ultra valve, the S3 Ultra, paravalvular leak is essentially gone. There's none. You just do a case and you expect to have zero leak with the Ultra system. And it gives you much, much, much more confidence to downsize in cases like this because the risk of paravalvular leak is much diminished. And so in summary, we know that there's a growing number of BAV patients being treated with TAVI, especially among younger patients. Bicuspid valves have variable anatomy, and each one must be carefully evaluated for best treatment options. In addition to valvular anatomy, we must assess root anatomy, ascending aorta, coronary anomalies. And I think especially in our younger patients, there is still a role for surgery. We must really be thinking about coronary reaccess and the lifetime management of aortic valve disease, because especially in our younger patients, they're likely going to outlive the valve you're going to implant, and we need to already think about what is going to be the next valve intervention after this first one. So again, thank you very much for having me here today, and thank you for your attention, and happy to answer questions at the end of the session. Thank you.
Thank you. Thank you, Dr. Vavalle, and this has been an outstanding talk, and we are very happy to have you here. We're going to leave the questions for the end.
Okay.
And sí, el doctor Alfredo Marino va a presentar algo sobre válvulas extremadamente calcificadas.
Hola, buenas tardes ya. Gracias por la invitación a SOLACI-SOCIME. Gracias a los panelistas que se encuentran arriba y a mis compañeros speakers. Excelentes pláticas las pasadas. Sí sirve esto para cambiar, ¿verdad? Perfecto. Me ponen la presentación en modo de presentación, por favor. Muy bien, pues vamos a tocar algunas palabras en cuanto a anillo calcificado. Vamos a ver las variables que nos meten en problemas, cómo todavía hay opciones quirúrgicas para la TAVI, para la válvula aórtica estenótica que no es TAVI. Y vamos a ver algunos mensajes al final que creo que hay que llevar a casa cuando estamos hablando de anillos, no solamente anillos, sino complejo valvular aórtico calcificado, porque tiene muchas cosas aparte del anillo. Para esta charla no tengo conflicto de interés. Y bueno, estos son los principales problemas que nos da la calcificación severa de un complejo aórtico, desde la fuga paravalvular, por supuesto, que sabemos que los que implantamos TAVI de manera profesional no podemos permitir nada mayor a una fuga leve, y ahora, como bien dicen, la Sapien 3 Ultra ya no debe de permitir ninguna fuga. Debemos de aspirar a resultados bastante más contundentes en términos de no dejar fuga, anormalidades de la conducción, la ruptura del anillo, que es algo que ya es fatal, por supuesto, la oclusión coronaria, y ahí tendremos algunas palabras, por supuesto, de stroke, que también tiene mucho que ver. Cómo la calcificación afecta, y es muy importante que le pidamos a nuestros imagenólogos cardiovasculares que no dejemos degradar la cantidad y la distribución del calcio, sobre todo cuando nos lo reportan. Muchas veces, y me ha tocado ver cómo implantamos algunas válvulas con reportes y no muy con imágenes de pronto. Todavía las casas se dedican a, también ellos, independientemente de los imagenólogos institucionales o de los hospitales privados, siguen dándonos todo el estudio de la válvula, pero muchas veces no lo conocemos, y conocer la cantidad de unidades Sagaston que se ve de calcio y también la distribución del mismo es muy importante, y aquí se ve como de derecha a izquierda en la gráfica la severidad y la distribución. Acá vemos como a mayor calcificación hay mayor riesgo de fuga paravalvular, y vemos cómo se encuentra la distribución del calcio muy hacia el seno no coronariano, coronariano izquierdo, con una espícula de calcio ahí, y vemos cómo el resultado posimplante nos demuestra una fuga paravalvular importante. Entonces, el calcio, que normalmente debe de ser un aliado a la hora de fijar la válvula, se vuelve un enemigo cuando las válvulas están altamente calcificadas y nos empieza a meter en problemas. ¿Cuáles son las variables que impactan en las complicaciones cuando estamos en presencia de un complejo valvular altamente calcificado? La carga de calcio, por supuesto, y eso lo miden tanto en extensión del mismo, en milímetros, como en unidades Sagaston, y tienen implicaciones a la hora de planear el procedimiento. acumulación asimétrica del mismo, la asimetría en la acumulación del calcio nos puede predecir desde trastornos del ritmo hasta ruptura del anillo, extensión a la raíz de la aorta, extensión a la vía de salida y conocer la cantidad de calcio en la zona de aterrizaje de nuestra válvula, porque es importante a la hora de planear el procedimiento. Perdón que está tan pequeño esto, creo que ustedes lo ven mejor que yo, pero esa es la cantidad de fuga paravalvular, el impacto que genera en fuga paravalvular. Incluso tenemos ahí un desglosado de las diferentes tecnologías y vemos cómo sí el tener calcio impacta mucho más en la fuga paravalvular y tenemos que hacer todas las estrategias que conozcamos y que nos sepamos para tratar de mermar esa fuga paravalvular. Ojo con las posdilataciones que nos meten en serios problemas y al final les haré un comentario de un caso que tuvimos en el 20 de noviembre. La asociación de calcificación con trastornos de la conducción y quiero que vean cómo en la medición tomográfica que tenemos ahí, en la reconstrucción lineal también de la misma, podemos ver dónde se encuentra el calcio, dónde se encuentra en relación a la continuidad microaórtica y al septum membranoso. Y el primer electro, el que tiene la letra B, es el preimplante y cómo cuando la cantidad de calcio es importante, subimos hasta 156 milisegundos la estrechez del QRS desde 94, que era el basal, sí tiene muchas implicaciones y sí hay que saber qué está pasando. Sabemos que cuando se encuentra en el seno coronariano izquierdo y cuando se encuentra asimétricamente distribuido, esto puede ser mayor. También la medida del septum membranoso, por arriba de 7 milímetros tenemos mucha más, por abajo de 7 milímetros tenemos mucha más probabilidad de un trastorno del ritmo que requiera colocación de marcapaso. La ruptura de anillo, y esto es algo a lo que le debemos de tener mucho respeto, mucho cuidado, y que estoy seguro que nos ha pasado a los que implantamos TAVI más de las veces que lo hemos diagnosticado o que lo hemos visto en la imagen. Y aquí pueden ver cómo de derecha a izquierda nuevamente se ve la aurícula, se ve el calcio, la espícula de calcio señalada con la flecha, se ve cómo se encuentra en el seno coronariano izquierdo y vemos cómo a la izquierda en el ecocardiograma, en la visión transgástrica, vemos cómo se encuentra la fuga y la ruptura de anillo y vemos cómo se forma una cavidad parcial que más o menos en el casi 70%, 80% de los pacientes a las 3 horas máximo, si no es que de inmediato en sala, nos da más manifestaciones clínicas, habiendo un grupo de pacientes que a pesar de ruptura de anillo hay un sellado espontáneo con la colocación de la válvula y no nos damos cuenta de lo que está pasando. También, para hablar un poquito de stroke, vemos cómo la incidencia de pacientes de alto riesgo va del 1.7 hasta el 4.8 y vemos cómo la incidencia en pacientes de bajo riesgo con baja cantidad de calcio es menor al 1%. La distribución bimodal, que ocurre en 50%, menos de 24 horas y otro 50%, más de 10 días. Aumenta 4 veces la mortalidad, la presencia del stroke, y aquí tenemos las complicaciones de las arterias coronarias y la lesión renal también en esta tabla. Aquí vemos el plano anular y tenemos que ver la distribución del calcio tanto en el anillo como en el tracto de salida, como en las valvas, porque esto tiene implicaciones a la hora de planear el procedimiento. Tenemos que conocer la profundidad de implante, tenemos que saber qué dispositivo implantar para saber si no vamos a dejarlo con peor gradiente por no expansión del dispositivo, por falla del mismo, o con una insuficiencia importante. Y miren cómo está la distribución del calcio normalmente según si es en el seno no coronariano, en el seno coronariano derecho, y si es arriba o abajo del mismo en esta reconstrucción. Vale la pena conocerlo. Y miren cómo en el anillo normalmente se distribuye en mayor porcentaje en el seno coronariano izquierdo. Y en el tracto de salida en el no coronariano, en el tracto de salida se ve mucha más distribución de calcio en el seno coronariano izquierdo. Fíjense cómo que la calcificación en el tracto de salida no da cambios en la sobrevida, pero sí nos da mayor fuga paravalvular y eso tenemos que ponerlo claro. ¿Por qué? Porque llevar la válvula a más, hay que saber tolerar un poco de insuficiencia, puede guiarnos a una ruptura de anillo o una ruptura ventricular a nivel del tracto de salida. El impacto de la calcificación en el tracto de salida entrando por transfemoral, también nos demuestra que podemos tener un poco más de mortalidad si no lo hacemos como debemos hacerlo. La gráfica lo demuestra claramente. Y aquí podemos ver la mortalidad por cualquier causa o el stroke a los 30 días, los puntos de seguridad los mismos, y a los 30 días la seguridad del dispositivo implantado. Hay que tener mucho cuidado cuando tenemos mucho calcio en el tracto de salida, porque sí podemos tener problemas en términos de mortalidad. La calcificación como complicación, y en ello podemos ver cómo la presencia de calcio en el tracto de salida sí tiene una P significativa en términos de mortalidad intrahospitalaria, sobre todo cuando se presenta en el seno coronario derecho. Hablar unas palabras de cómo podemos tratar este calcio. Sabemos que predilatar siempre nos ayuda, pero hay que hacerlo con mucho cuidado. En este caso hay un dispositivo que es para no implantar válvula y darle tratamiento a válvulas altamente calcificadas. Eso, a título personal, yo puedo creer que tratar una válvula aórtica hoy, con la evidencia que hay hoy, sin dejar colocada una válvula, pues no me parece que sea lo mejor, pero este dispositivo ciertamente puede adecuar la raíz de la aorta y el complejo aórtico para recibir una válvula de mejor manera. Yo creo que este tratamiento que le da a las valvas y esta adecuación, por llamarle de alguna manera, del dispositivo Leaflex puede funcionar siempre y cuando hoy se complemente con una válvula a implantar. Aquí tenemos cómo mejora muchísimo la hemodinamia del paciente. Parece que en términos de insuficiencia, en el primer estudio en vivo, que fue de 16 pacientes, 2 tuvieron stroke y todos los demás son estos los parámetros. Sí mejora mucho el gradiente, sí adecúa las válvulas para algo, o es un manejo de algo altamente calcificado, aunque el día de hoy yo no me quedaría con la paz de dejar este dispositivo solo, como se propone. Yo complementaría con la colocación de una TAVI después en condiciones mejores. Prácticamente creo que este dispositivo convertiría una válvula aórtica que está altamente calcificada en una colocación normal de TAVI de una válvula normal, y eso podría ayudarnos mucho a mejorar la zona de aterrizaje de la misma. ¿Qué mensajes llevaría yo de un complejo aórtico muy calcificado, que vale la pena agradar en cantidad de calcio en términos de extensión y unidades Agatston? Sabemos que para mujeres arriba de 1250 y para hombres arriba de 2050 es una válvula altamente calcificada y nos debe de hacer pensar en estrategias diferentes. En válvulas altamente calcificadas sugerimos el uso de tecnología autoexpandible, tolerando fugas con la misma, y les cuento una tragedia ocurrida en el 20 de noviembre, hace más o menos como mes y medio. Pusimos una válvula autoexpandible después de predilatar adecuadamente, quedó con una fuga ligera a moderada y pues dilatamos con ruptura de anillo, entonces tuvimos la misma complicación que con una balón expandible por no tolerar un poco de fuga, que creo que hubiera mejorado con el tiempo. La opción quirúrgica por mínima invasión sigue siendo una excelente alternativa en centros de alto volumen y adecuada mortalidad de la misma. Creo que hay válvulas a las que no debemos entrarle con TAVI y que todavía hay centros en donde se pueden hacer cirugías muy adecuadas y podemos quitar toda esa cantidad de calcio como lo hacen los cirujanos, y hay técnicas que ya nos permiten mortalidades muy, muy óptimas para los pacientes. Una adecuada planeación de procedimiento, que esto es algo en lo que siempre estaremos recalando. En términos de qué dispositivo seleccionar, sabemos que hay muchas aortas horizontales y que estaríamos pensando en una montada en balón, pero sabemos que con tanto calcio es mejor un autoexpandible. Sabemos que con tanto calcio a lo mejor es una bicúspide ahora por fusión de comisuras y calcificación de las mismas, y a lo mejor una tecnología supraanular mejor que una anular. Hay mucho que planearle al procedimiento y vale la pena tomarse el tiempo de hacerlo. Y también conocer las expectativas para anillos muy calcificados, cantidades de calcio asimétricas, tolerando fugas ligeras a traza de fuga, no más de esto. Sabemos que eso es lo correcto cuando ponemos TAVI. Pueden existir discrepancias entre lo reportado por eco y la tomografía, pero la reconstrucción oblicua transversa de la válvula aórtica por tomografía es el mejor método para conocer y gradar la cantidad de calcio. La distribución asimétrica del calcio deriva en mayores tasas de trastornos de conducción por la presencia de fuerzas exercionales a nivel del anillo, desplazando el septum membranoso pueden ser transitorias, pueden ser definitivas que requieran colocación de marcapaso. Nuevas opciones terapéuticas por sí solas o complementarias para la colocación de TAVI se desarrollan para beneficiar a pacientes altamente calcificados, como lo vimos. Creo que todo se debe centrar en la planeación del procedimiento, la selección del dispositivo y saber cuándo vamos a tolerar, en dónde y de qué manera una pequeña fuga contra una complicación mayor, que puede ser una oclusión coronaria, que puede ser una ruptura de anillo o que puede ser la necesidad de colocar un marcapaso. Creo que cada vez más el Heart Team sigue agarrando fuerza para la planeación de estos procedimientos y vale la pena tomarse el tiempo, ver la tomografía y medir toda la cantidad de calcio y la distribución del mismo que hay en la válvula. Muchas gracias por eso.
Muchas gracias al doctor Merino por su excelente plática también. Creo que podríamos renombrar la plática del doctor Vavalle realmente la plática inicial que se llama TAVI in Complex Anatomy, podríamos decir que es TAVI at the limits today, fácilmente. Creo que seguramente surgirán muchas preguntas para los dos ponentes, puesto que las pláticas han sido excelentes, los casos extraordinariamente provocadores. Yo le quería preguntar primero al doctor Goldsmit, al doctor Maluenda, que para ser buenos anfitriones, si tienen alguna pregunta para los ponentes.
Sí, la verdad que sí, las dos presentaciones excelentes, muy clarificadas, y siguiendo cambiando el título, como mostraron y cómo fueron resolviendo, no parecen casos complejos. Entonces, la pregunta puntual es, sabiendo que existen algunos disparadores, algunos componentes anatómicos y fisiológicos que no los podemos cambiar, y eso es lo que paciente de alto riesgo. La pregunta es, ¿qué es lo que hacen antes, durante y de manera alejada del procedimiento para seguir manteniendo ese riesgo bajo en esos pacientes que sabemos que son de alto riesgo?
In my opinion, you either win or lose with TAVI before you ever walk in the room. It's all about the pre-procedural planning. If you walk into the room with a good plan, having extensively evaluated the CT scan, understand where the risks are, and have a plan to address those risks, that gives you the best chance of success. Of course, sometimes unexpected things happen, but TAVI is a procedure where success is had by the planning that's put into the procedure ahead of time. I think as a community, we're moving away from surgical risk assessment as a way to decide who gets TAVR to anatomic risk assessment. In the old days, if you will, of TAVR, we used to decide if a patient got TAVR based on surgical risk. We now know, based on a number of well-done randomized clinical trials, that TAVI is preferred regardless of your surgical risk. But the patients that were enrolled in those studies had really good anatomy for TAVR. And so now when I meet a new patient for TAVR, my first question is, what's their anatomy for TAVR, not what's their surgical risk? And if they have good anatomy for TAVR, none of the high-risk features we've talked about today, I offer them TAVI. If they have high-risk features, then I ask myself, what's their surgical risk? And if they're low surgical risk, we may still consider surgery. If they're high or very high surgical risk, those are the patients then where we have to figure out a plan. And I think, as we gain more and more experience, we certainly are better at mitigating these risks. And there are things like basilica and chimney stents to help mitigate the risks of coronary obstruction. The most dreaded complication of root rupture, though, I think is very much helped by valve selection. I think that in heavily calcified annuli, we still tend to prefer self-expanding, and we will be more accepting of leak. I'd much rather have some leak than a root rupture. But I think with balloon expandable valves, you can be increasingly more confident in downsizing and still getting an excellent result, especially with the Ultra platform, which has really, really dramatically reduced the risks of paravalvular leak.
Yo creo que complementando el comentario, no solamente es hacer la planeación, porque me toca ver muchas veces en sala de hemodinamia que se planea bien, pero no se sigue dicha planeación, hay que seguirla, hay que cumplirla, hay que ser rutinarios a la hora de poner TAVI para minorar las complicaciones. Yo, además de lo bien expuesto por mi compañero, diría que antes de buscar el riesgo quirúrgico, lo primero que buscaría es cuánto tiempo va a necesitar el dispositivo del paciente, la duración del dispositivo me parece muy importante, porque a pesar de que tenga un riesgo quirúrgico si es un paciente de 87 años, probablemente lo llevaría a TAVI por la durabilidad del dispositivo. Y estoy totalmente de acuerdo que las válvulas balón expandibles, bien medidas con la simulación del anillo intercomisural, podemos ponerlas con mucha seguridad y mucha eficacia en reducir la fuga paravalvular en anillos complejos.
Doctor Rodríguez, doctor Berumen, ¿alguna pregunta del doctor Maluenda? Doctor Maluenda, por favor.
Ok, bueno, algunos comentarios puntuales de las excelentes charlas que hemos escuchado. Creo que mientras siga habiendo pacientes inoperables, pues seguiremos cruzando los límites que conocemos actualmente para la TAVI. Si bien algunos casos son excelentes resultados como los que presentó el doctor, detrás de ellos hay otros tantos historias de terror de pacientes off-label que no se ha logrado el objetivo, particularmente hablando del caso de los anillos grandes. Pues bueno, sí creo que se ha optado últimamente por la balón expandible porque forzamos el diámetro predeterminado gracias a más volumen, cosa que no podemos hacer con un autoexpandible que va a dar lo que tiene que dar. Con mucho cuidado, como lo mencionó el doctor, porque esta válvula se va a cortar mucho y cuando queremos que siga arriba a nivel de las valvas, pues de todos modos tenemos que empezar abajo porque va a subir mucho esta válvula. Con respecto a las válvulas con pacientes con insuficiencia aórtica pura, pues bueno, el resultado que tuvieron fue excelente. Me llamó la atención que el anillo no era muy grande, cosa que es rara en las insuficiencias aórticas. Quizá yo me orientaría más por una válvula autoexpandible en estos contextos, porque históricamente, pues digamos, las preocupaciones principales en estos casos son la necesidad de una segunda válvula o la embolización. Y con una válvula balón expandible, pues tenemos que tener cuidado. Las válvulas bicúspides, bueno, pues es un tema que siempre se ha mencionado. A estos pacientes hay que estudiarlos bien, cocinarlos aparte. Los primeros casos que se hicieron con los dispositivos de primera generación, pues parecía que todo iba bien. Luego hubo unos estudios con muy malos resultados, vinieron los dispositivos de segunda y tercera generación y actualmente parece que podemos tratar tranquilamente a estos pacientes, pero aún así con mucho cuidado. Y respecto a la plática del doctor Merino, pues bueno, en anillos muy calcificados, híjole, yo creo que hay que ver precisamente el límite donde, cuántos puntos de calcio te indican que tienes que predilatar, cuántos no. Tuvimos hace poco un paciente con 7,000 puntos de calcio y no era bicúspide, cosa que es rara. Casi siempre los pacientes con más de 5,000 puntos son bicúspides, y nos atrevimos a poner una balón expandible con un oversizing discreto, 5%, y quedó muy bien. Con una fuga leve, pero el paciente vivo. Entonces creo que tenemos de dónde echar mano para los diferentes escenarios, y pues solamente continuar haciéndolo con cuidado y con un heart team que estudie bien los casos.
Doctor Maluenda. Doctor Maluenda, adelante.
Yo quería, bueno, felicitar al doctor por las charlas, y un poco pensando, digamos, él abarcó todos los conceptos que rodean al procedimiento en el bicúspide, pero hay dos cosas que quedan siempre en el tintero. Digamos, la válvula, mejoraron el leak, mejoraron los resultados, pero los pacientes siguen siendo jóvenes y seguimos temiendo el stroke. Entonces, la pregunta para el doctor John es si hay en algún grupo de pacientes donde trata de hacer alguna terapéutica para evitar el stroke, ¿cuáles son y cuál es la técnica que usa?
It's an excellent question. You know, I think what you're asking about is the use of cerebral embolic protection. In the United States, most centers don't use it, in part because it costs a lot of money, it adds time to the procedure, and it adds an additional vascular access. There are some centers, mostly large volume centers, that are real believers, and they use it 100% of the time. We are a center that use it selectively, although I will fully admit that there is not a lot of great data behind how we use it. The data that we have shows that in general it reduces MRI lesions, but doesn't really reduce major clinical strokes. But we think the patients that are at highest risk for embolization are the valves that are heavily calcified, bicuspid valves, and valve-in-valve. And so in those cases, in general, we will use cerebral embolic protection. But our default, as of today, until there's more data to support its routine use, is to not use it.
Ok. ¿Alguna pregunta, Luis?
Bueno, a mí me gustaría hacer unas preguntas más. Una pregunta más sobre todo al doctor Goldsmit y al doctor Merino. ¿Qué opinan sobre la predilatación? Algunas bibliografías refieren que predilatar permite ver el comportamiento del desplazamiento de calcio, de los lípidos, cómo se van a incorporar, pero definitivamente está el riesgo del stroke. Entonces, me gustaría saber su planteamiento de la predilatación. Y un segundo punto, ¿qué preferían ustedes mejor en una válvula calcificada y deformada? ¿Elegir una válvula pequeña y sobredimensionarla o al revés?
Ok, en términos de la predilatación, yo creo que hasta en un 70% de los pacientes es posible hacerlo sin predilatación. En esos pacientes sencillos, no calcificados, bueno, poco calcificados. Nosotros somos un centro que no predilata mucho el 20 de noviembre, especialmente yo soy poco predilatador, pero sí creo que cuando entramos al territorio de las anatomías complejas, del calcio, a lo mejor de las bicúspides, hay que preparar las cosas para que la válvula aterrice de mejor manera y ahí sí hay que predilatar. En términos de una válvula pequeña, llevarla a más o escoger una válvula grande y no dimensionarla tanto, en las válvulas pequeñas, por lo pronto en la Sapien podría decirte que o hacer crecer más la válvula 21 y 23 no es lo más recomendable. Y eso está plenamente descrito. Si nos vamos a ir a anillos más grandes y la decisión es llevar a más una 26 o una 29, sin duda las puedes llevar a mucho mayor volumen. Las puedes llevar a un oversizing de 4 o 5 centímetros de contraste con agua mayores, no tiene problema, pero en la válvula 23 y 21 yo no las llevaría más, preferiría irme con una 26 más pequeña, o si es la 21, una 23 no llevada más de nominal, por la deformación de las valvas, por el riesgo de fuga y por la tensión que se genera en los postes de las mismas.
You have 2 minutes. Do you have any other comment?
I probably still pre-dilate more than most of my colleagues. I certainly don't do it routinely, but I will do it in bicuspid valves. I will do it in valves that are heavily calcified. And I will do it especially in valves where there's severe calcification between the non and the right coronary cusp. And that's because that's usually where the wire tends to track. And if you're going to have difficulty crossing the valve with a transcatheter valve, it's usually going to be because there's calcium in that location. When I do pre-BAV, though, I usually use a very conservatively sized balloon. So I frequently will use balloons in the 16, 18 millimeter range. My goal is strictly to help enhance delivery of the transcatheter valve so that I can more easily cross the valve, but also more easily do fine positioning of the valve as I'm expanding it. If you can almost always cross the valve without pre-dilating, but many times that valve is then very tight as it fits between the calcified leaflets and limits your ability for fine movement, either up or down, ventricular aortic, as you're expanding. And so in heavily calcified valves and bicuspid valves, I will still pre-dilate, realizing I do it more commonly than most of my colleagues, but it's certainly no longer the standard for most cases.
Well, thank you very much for your excellent presentations. We're just on time. I would like to make a question, but I will do it off the table about the shape that we achieve with this kind of devices. How do they impact after implantation in the durability of the same devices? But that would be for a later discussion. So thank you very much to everyone. Muchas gracias a todos.